Welcome everyone to this session, which is mental health and addiction. And I have picked really probably the most knowledgeable and most heart-centered person to lead this session for us. I don't know in all of my 16 years of working if I have ever seen anybody as dedicated to the success of somebody else. Just, I mean, has a huge heart and is not afraid to share it. You handle yourself with dignity and grace in all situations, and I am constantly learning from you. So I'm super excited to welcome you to the mental health and
Thank you
addiction.
so much. Wow, that's so
Yeah.
kind. Thank you. I'm
Yeah,
very
so
excited to
why
be
don't you
here.
open up and tell us a little bit about yourself? Why addiction?
Well, I'm sorry.
Why addiction?
So it's a good question, and it's a question that I think can be answered really by the universe. A higher power, however, a person conceives powers outside of their own, because the truth is it wasn't particularly intentional. When I got into social work graduate school, somebody who I met, who I respected, said to me, "You really need to do an internship in addiction." And that was the first time I ever considered addiction. It hadn't been to my awareness, part of my life before that. I didn't know much about it, but I trusted him. And the way that he explained it was, you're not going to meet a person. You're not going to meet a person who you're going to help as a social worker who isn't going to be touched by addiction in some way. It's just not possible. And some of them may not know it. For some of them, it may be them personally. It may be a few generations removed. But if you don't understand it and understand the power of this disease and how it impacts people directly and indirectly in so many ways, then you're not going to be able to help people, whether they're coming to you for support with addiction or something completely, in their mind at least, unrelated. So that was enough to convince me. And I started an internship at primary addiction treatment program. And there were people there who had some mental illness, but it wasn't major mental illness. They thankfully were one of those places that knew that there were presenting problems that they had did not have the skills to, help people with. So
Mhm.
they referred out for people who presented with more complex mental health conditions. So I was able to really just learn about addiction there. And and then from there, fell in love, really, honestly, with the population and just learning. It was just fascinating to me. And so um, heartbreaking and also heartwarming at the same time. The power that um, recovery has to transform people's lives, entire families, generations to come for decades and decades. It just spoke to me like, I got to get involved in this. I got to stay involved in this. I got to see, where this can take me and how many people I can help, and really through a combination of my work and training and effort. It takes a lot of effort, as you know, and also a higher power and other people's willingness to be part of the solution in their own lives. I'm so blessed to be able to say I've experienced and, observed so many miraculous transformations over the years. So it wasn't something I set out to do when I set out to get into this field, but I'm great, beyond grateful that it's how it turned out. So
That's right. Yeah, I think the accidental path, right? The
yeah.
the coincidental path that ends up
Mm-hmm.
being like, hang on a minute. I wasn't supposed to be a recovery advocate, but yet I look back and my whole life prepared me for this.
Mm-hmm.
It's a
So
calling, not a
true.
job, right?
Yep.
And it needs people that are strong with big shoulders because you can't wear your heart on your sleeve in this industry. You will crumble. So on that note of the mental health of the mental health providers, let's talk a little bit about what you have been seeing in the last few years as far as that shift that I was talking about from becoming primary mental health, primary addiction to primary mental health.
hmm Well, it's an interesting perspective that I have had since the pandemic because um thankfully this is another gift from a power greater than myself. I stepped down from a position as a clinical director in a treatment program months before COVID-19 ended up hitting. So obviously I didn't know that was going to be coming, but I was grateful, in hindsight for the timing. And I've been in private practice since then. So I I still am in touch with programs, and so I have a pulse on what they're seeing at a more macro level. But as far as what I'm seeing, by the time clients get to me at an outpatient level, they've completed treatment, or maybe they haven't even had to go to treatment for a while and they've been doing pretty well, but they want to get some support for primary mental health issues, is a significant increase in anxiety disorders, and particularly um, disorders with an obsessive compulsive related feel, and additionally PTSD. So those are those are diagnoses that have been around for a very, very long time. Recently, we've made some shifts in how we characterize some of the obsessive related disorders, but bottom line is, like, they've been around, for the most part forever, but due to, I think, some social factors and well, a lot of different factors actually, um, they've become more prevalent, more talked about, more well researched.
Mhm.
People are um, better equipped to treat, especially the PTSD and the obsessive compulsive disorders, than we have been before, and they're being talked about more. So it's a double, I mean, it's good and bad in that
Mhm.
they're on the rise for various reasons, but at the same time, we're able to support people better than we ever have been. Um, Major depression is also something that I've always seen and goes hand in hand with addiction, but nowadays it's it's uh, very separate as well. So I see people who come to me for help 5, 6, 7 years sober. Their depression is not intertwined with being in early recovery. They're not dealing with the situational depressing factors that somebody
Mhm.
would be when they're just getting off of drugs and alcohol and facing, the wreckage of the past and rebuilding from a pretty low spot and repairing relational damage, all that stuff that comes hand in, brings depression. Most people in early recovery, have some symptoms of that circumstantially. But what I'm seeing
Right.
is people coming to me like, my life actually is pretty good on the outside. I've built my business back, for example, or I've got my relationship with my wife back, this and that, but I can't sleep. I'm having these episodes, I'm getting tearful out of nowhere. I don't know what's going on. I'm finding myself really hyper vigilant. Um, I'm thinking, having these thoughts that I've never had before. They're kind of scaring me. I don't think I'm going to act on them, but they're coming out of left field and I don't know what to make of them. This isn't me. I don't know what's going on. Those kind of things that really have nothing to do with drugs and alcohol, but have more to do with other factors that they're not accustomed to. Like they don't understand and they're worried about.
Yeah, and you bring up a good point there because we had a mutual client, um, and his mental health issues needed to be addressed while he was also addressing his addiction. To the point where this particular client had to go back into inpatient treatment. And, the way in which that was handled, Jessica, was, I think, a model for how clinicians should be handling people. It is a separate issue, right? Just because you go to treatment, your depression, your anxiety, that's not just going to lift. Like you said, there's situational depression, and then there's clinical. There's debilitating anxiety. There are things besides drugs and alcohol that can keep people down, and that people need ongoing treatment for. And thankfully that young man, is doing well, and came back, and we emptied the house because everybody else was bullying him. But we all struggle. We all struggle.
Yeah.
It's the way in which we cope. And let's talk about that for a little bit, about breaking that cycle. Um, Breaking that cycle of addiction and mental health. If you're just new to this, like, how do you know where to start? Do I start with the addiction? Do I start addressing the mental health? Do I try to do it at the same time? What do I do?
Hmm. Yeah. I think and that's something that mostly that question falls on parents to answer, um, or sometimes spouses, but usually the person who's struggling has the least ability, right, to navigate those um, decisions and even really understand what's going on and what they need. And you would think for families that are thinking more clearly and are, educated and wanting to do right by their loved ones, that it there would be some pretty clear direction, for them,
Mhm.
but it's unfortunately not as clear as I would say it could be, because for professionals who, are educated and trained, at a high level to distinguish between what are immediate priorities, what can be deferred, what needs to be established as a foundation first, and then second, and what kind of environment is most conducive to moving a person through the phases of recovery for whatever the dual diagnosis is. It's not it's not that complicated, but for a common for somebody who doesn't have that, it's almost impossible to know. So I think unfortunately, most people end up in the wrong place, starting in the wrong with the wrong priority, with the
Mhm.
wrong um, focus, and end up in some cases getting worse before they get better. And in those cases too, unfortunately, sometimes they incur even more trauma, setbacks, and can get disillusioned with the whole recovery process because it just wasn't laid out the way that they needed it to be. For
Mhm.
example, I've worked with somebody who, by the time they got to me, thankfully they were doing well. But when I learned about what they'd been through the previous few years, it was so much trial and error. And the family was told to put, this is what they need and put them in this place. And after a few months, they decompensated further, and then let's put them in this place. And then they were told, okay, that's just bring them home. And that it was so much experimentation. And for me, and I think, a lot of people who, there are a lot of good people, in this field who know what they're doing and have um, the unbiased and, just understanding of what works and what doesn't work. Um,
Mhm.
in 5 minutes, I'm thinking to myself, this poor kid, like what he went
Right.
through, it was such a shame. Years of his life, his family, the trauma that they experienced as a result, the secondary trauma that's very much real as well, all avoidable. So I think that's a
That
big reason why
vicarious
you
trauma,
wanted
that
to.
compassion fatigue, all of that stuff that
Mhm.
comes along with the addiction and the mental health. Can you talk
Yeah.
for a minute about cognitive behavioral therapy for both of those things? And because we talk about that in the rooms a lot. You can't think your way into behaving better, but you can behave your way into thinking better.
Yeah, I love CBT. I could talk about it all day, but before I do, I just want to get a little clarity on when you say talk about it on about both things. What do you
On both the addiction and the mental health. The
gotcha?
cognitive behavioral therapy can be an effective strategy
Yes.
for both
Yeah.
of those diagnoses.
Yeah. I think it's critical. It's indispensable. It's more than just that it can be effective. In my experience, it's the most effective, and most people are good candidates for it, and they can participate in it. A little bit of resistance comes in when it comes to assignments, outside of therapy sessions, just human nature. I don't want to do homework kind of thing. But if they're willing to do it, it works, 10 out of 10 times. And even if they're just willing to do it in session. So for an example, it's very common that people, when they get into early recovery, they're told you have to branch out, right? That's a universal suggestion. You got to get a tribe, a fellowship. That means you have to introduce yourself to people who you don't know. Usually that happens at meetings, most conveniently, most commonly. So for somebody with social anxiety, because you mentioned bullying. Bullying is on the rise throughout this country. Cyberbullying, I mean, social media is a big part of what's allowed that to explode the way that it has. Suicide, the leading cause of death among young adults 18 to 25, heavily linked to childhood experience with bullying. So uh, many of the young adults who I see, and I know my colleagues see, will have these awful, heartbreaking stories about how they were bullied when they were younger, whether it's through social media or kids at school, or whatever. We know the different ways that bullying happens. And so when you say this to a 23-year-old with social anxiety, and in some cases even PTSD related to bullying, you have to go up to a guy who you don't know and ask him to be a sober support to you. And then you have to get his phone number, and then you have to call him and ask him to bring you to a meeting. There's always going to there's often going to be resistance to that for a person with perfect mental health. It's uncomfortable. It's awkward. It's not something that people usually do outside of a recovery environment. I get somebody's phone number and ask them for a ride and to hang out, and essentially, will you be my friend, because I'm at a pretty broken place in my life and I need positive influences. Um, and of course, people who are in recovery and around it know that that's part of the deal and welcome. And for the most part, anybody who's really working in a good program would be honored, right, to take this newcomer to a meeting and spend time with them, and so forth. But it becomes a therapy issue when this, not, well, I was going to say kid, they're not a kid, but the inner child in them, whose experience going out on a limb socially has been to be burned badly in the past, hears this and has a panic attack and can't even imagine. And so then the CBT, okay, what are your thoughts? What are the beliefs that you have about what's going to happen when you go up to this guy that you've seen now at 5 or 6 meetings, who chairs the meeting, who always has a smile on his face and has said, please come to me for anything. What is your brain telling you is going to happen when you go up to him and introduce yourself? And where does that belief come from? And is that outdated? And what if that does happen? What's the worst thing that can happen? And what is the percentage likelihood that that's what's going to happen? And what can we put in place behaviorally for you to cope if the worst case scenario does happen? And what if the best case scenario happens? So the CBT, the cognitive
Mhm.
exercises, and then the behavioral interventions that CBT promotes and outlines for us are exceptionally useful when it comes to building these skills and these habits in early recovery that are often blocked by the mental health symptoms.
Right. And masked, right?
Yeah. Yeah, people will
Um,
say, "Oh, this kid's just lazy.
yeah.
He doesn't want
Am I
to,
lazy or am I crazy, right? That old song line. Um,
hmm
and a lot of things I think are hard for people to say this is an illness. Um, and not just say this is just bad behavior or no morals, no ethics, no values, whatever the case might be. And
hmm
that's why we're having events like these to open people's eyes and to see that, I mean, whether it's poisoning or accidental addiction or intentional addiction, how you got there doesn't matter. It's what you do now.
hmm
And on that note, so I've got a free gift from you, Jessica, for everybody. The dashboard link, I just pulled it up and it actually your link goes, it says Carrie Lewis. So obviously, like Carrie said, first summit, we're working it out. So that link will be fixed. But you want to tell people about
Sure.
your freebie?
Sure. Yeah. So I'm really excited. I'm going to be hosting a live sort of masterclass event in a couple of weeks about the importance of everybody's mental health. So when you're talking about caregiver, we're talking about burnout and secondary trauma. It's all too common for family members to lose their own self-care, lose track of their own mental health as they're supporting a loved one who's in crisis, and needs more of their attention or focus than they do for a time, and then all of a sudden they realize, I'm having anxiety, I'm having depression, my self-care has gone by the wayside, I'm not feeling myself, I'm not feeling right. And when that happens, as the old adage goes, like, you have to put the oxygen mask on yourself before you can put it on anybody else. You suffer, and then you're really not able to be at your strongest for the loved one who you're trying to support in the first place. So
Right.
it really is important, truly, for everybody. Truly, truly. It's not just something to say, it really
No,
matters.
it's no, we've seen it, we've seen how much we've seen it throughout the years, right? The families
Hmm
are struggling just as much as the individuals are.
And
And
when
they
they burn
don't, there
out,
is
they can't
no,
do their part. And when they can't
yeah,
do their part, everything falls apart.
yeah, good. I really, really appreciate you coming on, Jessica, and giving us our free gift. So if you are a loved one or know somebody that is, we know that people don't know that these resources exist. So if you share them, we'd really appreciate that. That's how the word gets around. You don't have to suffer in silence. Thank you, everybody, for being here, and we will see you back in the main.